Intersex is defined as the presence of both male and female external or internal genital organs. This situation can be very confusing. By 5 weeks of gestation, there is presence of undifferentiated bipotential gonads. By 6 to 7 weeks, so in another week's time, SRY gene, which is an important one on short arm of a Y chromosome, will decide whether the undifferentiated gonad will change into testes or ovary. SRY gene means presence of testes. Testes has two type of cells, Leydig cells and Sertoli cells. Leydig cells secretes testosterone that converts into an active form dihydrotestosterone. Sertoli cell secretes anti-Mullerian hormone that regresses the Mullerian duct, but it promotes development of Wolffian duct. Negative SRY gene means development of Mullerian duct as it promotes the development of female genitalia. This entire process gets completed by 9 to 18 weeks of in utero life. Determination of sex is by chromosomal sex testing that reveals XX or XY chromosomes, genetic sex testing, external genitalia and internal genitalia examination that reveals external sex organs and internal sex organs like testes and ovaries, psychologic sex, and sex of rearing. It can be differentiated into female intersex, that is an association of female gonad with male external genitalia, male intersex, that is an association of male gonad with female external genitalia, and then true intersex, where an individual possesses both ovaries and testes with a complete ambiguity of genitalia. In female intersex, congenital adrenal hyperplasia is the most commonest cause. 21 hydroxylase deficiency is present in more than 90% of the cases. With this, there is a lack of cortisol, corticosterone, and aldosterone formation. The entire pathway gets converted to androstenedione that increases production of androgens, especially testosterone, that gives rise to hirsutism and virilization with presence of ambiguous genitalia. Ambiguous genitalia at the time of birth can be a confusing picture. Such patients in puberty presents with amenorrhea and hirsutism. On clinical examination, we find enlarged clitoris, presence of penile urethra, decreased sodium and increased potassium due to deficiency of aldosterone, and labial adhesions. From investigation point of view, chromosome testing reveals that it is a female child with 46XX. Ultrasound shows presence of uterus and ovary, and blood test shows high levels of 17-hydroxyprogesterone, low sodium and potassium. Next in female intersex is Turner syndrome. This happens when there is a deletion of a genetic material from the short arm of a X chromosome. With investigation, chromosome testing shows 45X0 as there is loss of 1X. Estrogen levels are quite low. As the estrogen level is low, the pituitary center will produce increased FSH and LH, and this patient also has multiple autoantibodies. Clinical picture shows these patients have short stature less than 150 centimeters, neck webbing and low hairline, presence of cubitus valgus with a deformity of hand, broad chest, short fourth metatarsal. Secondary sexual characters are absent. There is presence of cardiac and kidney abnormality, which includes coarctation of aorta and horseshoe-shaped kidney. So treatment of congenital adrenal hyperplasia is with hydrocortisone therapy. This decreases the levels of pituitary ACTH and supplementation with mineralocorticoids as they have reduced sodium levels. From a plastic surgery point of view, these patients will need clitoroplasty and vaginoplasty, and they will be read as females. Treatment of Turner syndrome is providing estrogen and progesterone at puberty and at least until menopause. If there's some amount of eggs present in the ovary, then freezing can be done quite early, though it's very difficult to diagnose and do this. Pregnancy with an egg donor and regular DEXA scan to identify and treat osteoporosis. Now, in male intersex, androgen insensitivity syndrome is the most commonest one. In this, there's presence of receptor deficiency or resistance to the levels of androgens in the body. Patients presents with amenorrhea. External appearance of the genitalia is that of a female. Internal gonads is XY or testes. There's presence of breast development. Vulva is present in such patients. If you perform an ultrasound scan, it shows absent uterus, upper vagina and ovaries, but there's presence of blind vaginal pouch. Investigations: karyotype testing shows XY. Serum total testosterone levels are high as there is a production of hormones. The only problem is the receptor level. Serum estrogen levels are also high as there is a peripheral conversion of testosterone to estrogen. Serum luteinizing hormone levels remain normal or high. Definitive diagnosis of this condition is through gonadal biopsy. It shows absence spermatogenesis. Next condition so the treatment of androgen insensitivity syndrome is through an appropriate counseling, offering vaginoplasty as this patients will be reared as female, gonadectomy as there is an increased risk of gonadoblastoma and dysgerminoma, hormonal support with estrogen to maintain the bone mineral density. Male intersex is Klinefelter syndrome, in which there is presence of an extra X chromosome, 46XXY. There is presence of poorly functioning testes. The chance of this happening is 1 in 500 to 1000 cases. Patients do well as they have a normal life expectancy. The classical appearance of such patients: they are tall, they have clinodactyly, which means pink curly fingers, flat feet. And in contrast to the androgen insensitive syndrome, this is not an inherited condition. Androgen insensitive syndrome is an X-linked recessive condition. Investigation shows presence of low serum testosterone levels. Chromatin study shows presence of a bar body in a male fetus. Karyotype shows presence of 46XXY, which is a definitive diagnosis, and confirmation is through a gonadal biopsy. The next is the Swyer syndrome, in which the karyotype of the individual is 46XY, meaning male, but the external and internal genitalia, there is presence of female. That includes vagina, vulva, uterus, tubes, cervix, and ovaries. The reason behind this is presence of defective SRY gene. Gonadectomy is recommended to prevent cancer, and estrogen and progesterone supplementation is given to such patients. So the summary of intersex is: the incidence is 2 in 1000 patients. Female intersex means internal genitalia has ovary and external genitalia is of male. Male intersex means internal genitalia is testes and external genitalia is of female. True intersex means both ovary and testes are present. Diagnosis of the above condition is through karyotype, gonadal biopsy, and sex chromatin study. So this is the final slide showing conditions in which there is presence of female and male intersex. So in the first condition, which is a female intersex, congenital adrenal hyperplasia, there is presence of ambiguous genitalia at birth. Karyotypic testing reveals 46XX, and diagnosis of this condition is through a serum blood test of 17 hydroxyprogesterone. The levels are higher than 800. Second condition, which is also a female intersex, is Turner syndrome. The phenotype appearance is very classical of Turner's patient. Karyotype is 46X0. Blood test shows presence of low estrogen, increase follicle stimulating hormone. The third type is a male intersex, which is androgen insensitive syndrome, which has karyotype 46XY. Definitive diagnosis is through gonadal biopsy. Klinefelter syndrome again has a typical female phenotype with features. Biopsy and karyotype reveals 46XXY, and the diagnosis is through a gonadal biopsy. As you can note, in the female intersex, the karyotype will have double X or 1X only, and in male intersex, there will be presence of Y, but in Klinefelter, there is presence of double X.